So any questions, comments on the panel? Yes, Andrew's going to do the deed.
How do you measure your outcomes from your events when you're saying you've got 13,000 people? We've tried several ways to do that, using attendance sheets and sign-on sheets and clickers, and that's one of the things that we find really difficult to get right. So just interested in that.
Thank you. I guess with our stalls, like ourselves, is we do have a sheet. So we only mark down anyone that we actually have a brief intervention with, and then we get their smoking status. So obviously a lot could be non-smokers, and these stalls are held at clinics and then our extra events. Obviously our bigger events, it is a lot harder to capture absolutely everyone, and at these stalls we actually have our pledges and our surveys involved in that. But also we have a lot of people on the ground, so we are constantly training our staff and really pushing that they capture the data, because that's our evidence. So I think for last year we just had under 10,000 surveys collected for 12 months, and that was across all of our teams, our 6 regions. Luke, do you want to add to that? No. Yeah. So. A lot of it's on iPad. Yeah. So we use a program called Qualtrics. So we changed over in January last year from SurveyMonkey. So with Qualtrics, you don't need internet access. You can just use it offline. Once you get back to the office, you upload your data, and then it's more efficient. So yeah, we have iPads that go around, or they could use mobile phones if needed, depending on the community.
Just for the Deadly Choices training, have you got any plans to actually upskill any of your Indigenous health workers or anything to become tobacco treatment specialists?
Yeah, so we're doing that at the moment. So we've got a sort of like a phase 2 training that we do with our Aboriginal health workers. We'll work closely with our regional pharmacists, so we do a lot of that training with them, plus we use our other guys that we use with crit skills and stuff like that, part of our training that we do for our Aboriginal health workers. But in saying that, we're doing the whole clinician itself, so it's not only just the Aboriginal health worker, we're actually doing from GPs to obstetricians, so everybody in the clinic that they understand, because everybody sort of sees smoking somewhere in their discussions that they have. So that's sort of how we're doing it, and that's our phase 2 of our training that we do. We're trying to do that approach for across our state, so not only just South East Queensland, we're actually doing that statewide.
So actually registrations?
We're hoping so, yeah.
Oh, sorry.
Thanks. One of the questions that we're going to pose in the afternoon is around, well, we're going to ask you to reflect on budget, everyone to reflect on budget, because interventions have a cost, unfortunately, and we have finite resources in government. Was your program cost intensive? Did you think it was value for money? How would you reflect on that?
Well, as those of us who had innovation grants under the TIS program may recall, can I be honest?
Yes, please.
So those of us who had innovation grants under the TIS program may recall that they were funded for, when they were first announced or first put out, it was for a 2-year program, and so 2 years isn't very long. When we actually were awarded the grant and we got the funding, that was in November, so that actually reduced our time frame from 2 years to just over 18 months. And so for a smoking cessation and pregnancy intervention, has a maximum length of 18 months, and given that a pregnancy is, like 9 months, that certainly impacted the number of women that we could include in our intervention. It was a relatively costly model. I think a lot depend, and you ask about cost effectiveness, and that was a criticism of our program from departmental folk, that it wasn't value for money. But as I said, that if we had 41 women who enrolled into our program, and 45 babies, at least 45 babies born of those 41 women. Those 45 babies had a better start in life than they would have had they not been, had their parents, or mother at least, not been involved in the program. And Tom talked earlier about the epigenetics and genomic impact of intergenerational trauma. And I guess I would suggest that the value for money in not doing anything and addressing the needs of individual people is way higher than what it costs for a program that actually supports women lifelong. Yeah, it's like these kids not only had a better start in life, that better start in life lasts the lifetime. And if we're looking at trying to change life expectancy, improve life expectancy for Aboriginal and Torres Strait Islander people, that has to start prenatally. It has to start with the health and well-being of the mother and the family. And I mean, I could go on and on. I
don't worry about going on.
Words fail me when I start to, when I reflect on being told that our program is not value for money.
Okay, any last question before we move on to presentation? Thank you, panel.